NextMune is proud to partner with Biogal on these educational global opportunities. I would now like to introduce Dr. Richard Ford. Dr. Ford is an emeritus professor of medicine in the College of Veterinary Medicine at North Carolina State University. A graduate of Ohio State University, Dr. Ford practiced small animal and equine medicine prior to completing the internal medicine residency at Michigan State University. He taught internal medicine at Purdue University and North Carolina State University. He is board certified by the American College of Veterinary Internal Medicine and is an honorary diplomate in the American College of Veterinary Preventive Medicine. Dr. Ford is the lead editor of the AHA Canine Vaccine Guidelines and a co-author on the AAFP Feline Vaccine Guidelines. Outside of veterinary medicine, Dr. Ford spent 28 years with the U.S. Air Force as a biomedical scientist. He retired from the USAF Reserve as a brigadier general, where he was assigned to the Office of the Air Force Surgeon General at the Pentagon. Dr. Ford, thank you for taking the time to conduct this webinar. I am looking forward to your presentation.
Well, thank you very much, Megan. I appreciate the introduction. And if I could, I would like to extend a welcome to all of you globally who have elected to tune in to the webinar. This is a very special opportunity for me to communicate with you regarding a new and emerging technology for small animal practice. Before we actually begin, I wanted to clarify the two primary objectives of this relatively short webinar. Number one, I will introduce you to the VaccCheck antibody test kit. And this is truly the newest technology for in-clinic testing and measuring of protective immunity in individual patients. But secondly, and the focus of the presentation today is to address the application of the technology in practice. And as we do this, I would like to highlight the fact that there are misconceptions. There is misunderstanding about the role that antibody plays in a diagnostic setting. If we could have the first slide, we'll begin. As we go through this, you will have the opportunity through the question and answer section on your computer to inquire as to particular questions. At the conclusion of the seminar, we will attempt to address as many questions as we possibly can. Although we have a very large audience, we will do our best. To begin, I wanted to address a very short video for all of you. It's a video that demonstrates, in this case, the green pathogenic virus that is attacking the dog. This invasion or infection is what begins this very complex immune response in which antigen-presenting cells activate lymphocytes. Lymphocytes ultimately make B cells. But as the virus actually invades the patient, the antibody, the B cells of the immune system begin to produce antibody. The antibody seeks the invading virus, neutralizes the virus, and saves the dog. Now, I can speak from personal experience that when I graduated from veterinary school, this is all that I remembered about immunology. I suspect that's probably true for many of you as well. But the immune response is far more complex than what we see here. We are talking about measuring antibody, circulating antibody in the individual patient during this webinar. But there's more to the immune response than just the antibody. It's very important to understand that antibody is a protein, and over time, antibody will dissipate if there is no stimulus to provoke boosting of that antibody. The true longevity of immunity is based on the lymphocyte. This is what's termed immunologic memory or B cell memory. This enables the patient to remember that invading green virus and years later to redevelop antibody very quickly and save the patient. So as we go through this, I want you to recall or remember the aspect of immunity that is contrived in memory. It's a very important part of this whole story. One point that I must emphasize is the opportunity to test for antibody is truly increasing around the globe in veterinary medicine. And I have looked at why this market tends to be emerging at the pace that it is. In other words, what is driving the market today? And you have to go back a few years to remember that when vaccination guidelines were published by the American Animal Hospital Association, as well as the World Small Animal Veterinary Association, there was a recommendation to administer core vaccines at an interval of every 3 years or longer, rather than every year. Veterinarians did not trust that recommendation. And as a result, veterinarians wanted to be able to actually test the individual patient in order to prove to themselves that the vaccines had longevity, that antibody would last for a longer period than just 1 year, which of course it does. But as more and more practices begin to accept longer intervals between booster doses of core vaccines, another factor has begun to play in veterinary medicine, and it started in human medicine. Several years ago now, a physician published a paper, which I'm sure you recall, that suggested that if you vaccinate your children with the measles vaccine, that would increase the risk among children for developing autism. Even though that study has been completely discredited and proven not to be true, there are many hundreds of thousands of people who will not vaccinate their children against measles vaccine even today. And now, with the coronavirus vaccines becoming widely available throughout the world, the public health community has expressed great concern over individuals who are reluctant to give their children or themselves a coronavirus vaccine for fear that it might cause injury, or it would perhaps lead to adverse effects. And interestingly, in veterinary medicine, we are experiencing in many countries clients who are concerned over potential risk associated with vaccination. That concern over risk today has been a major contributor to the evolution of the market for testing individual dogs and cats for antibody rather than just administering a vaccine. So as the public becomes more and more aware of immunology through vaccines, virus variants, antibody response, antibody testing, I think veterinary medicine must pay attention to the concerns of these clients. And this presentation may offer you some options. Now, let me address the history of antibody testing in veterinary medicine. It did not start in the companion animal arena. It actually started and has been used for many years in production medicine. For example, in poultry or flock medicine, the producers will routinely test representative birds in a large population for infection. They do this through a testing kit device that allows them to evaluate 10 or 12 or more infections in one test kit. They're screening the population. Each week, they will kill a few birds within a pen in order to determine the antibody levels for a series of different bacteria or viruses. Each week, there's some background noise, but then one day, in one pen, for one virus, there's a large amount of antibody circulating in these birds. And it suggests that the population at large is at risk. And to manage that risk, they will kill all of the birds in that pen in order to reduce or save the population that is at risk for that particular virus. When millions of birds exist within these large flocks, it's critical to manage disease daily or at least weekly. But now, if you see what's happened in veterinary medicine, the market has shifted from herd surveillance to actually, what's the antibody level in that cat or that dog? And this request or demand within the profession has actually resulted in the evolution of newer and advanced technology that enables individual practices to test individual patients. And this is truly a new and emerging technology. But as with any new technology used in practice, there is confusion, there is misunderstanding of how the technology can be applied. This is very important for all of you watching this particular webinar. There are 3 questions that must be addressed with this type of technology. Number 1, is antibody testing a valid indication of immunity? Does it really correlate with protection? It's an important point. In fact, this is one of the major misconceptions or misunderstandings that I hear from practicing veterinarians who were actually taught, no, antibody is not a good indication of protection. I hope to change your thinking on that. Second, why would I test? What are the reasons this individual dog or cat would need to be tested with for the presence of antibody? I think this may surprise you, as we'll spend some time addressing that. But the ultimate question for the individual clinician is, given the test results, what's actionable? What should I do? How do I manage the patient based on the test results received? I think these are 3 key questions that I would like to concentrate on throughout the remainder of this webinar. So to begin, let me be very clear that we're talking about serological testing or antibody testing. And we're specifically looking at vaccine-preventable disease. I want to be very clear on that. Now, when it comes to the technology of testing for antibody, as a clinician, I think you should understand there are 2 general levels of or categories of testing. One is the quantitative testing. And by laboratory terminology, this is a common reference standard. In practice, we are more likely to utilize a qualitative testing platform. Now, what's the difference between the two? And I think this is important. When doing quantitative testing, this is the testing platform that leads to an actual antibody titer. This is a dilution. This gives you a proportion or a concentration of antibody in that individual patient, and it's represented by a number. The dilution, in this case, 1 to 1,600, is representative of the concentration. The titer, the actual titer number, is 1,600. The higher the number, the higher the concentration of antibody. But I want to be very clear about this point. It is not the concentration or the amplitude of the antibody titer that determines the level of immunity. You must understand that a patient is either immune or they're not. There is no patient that is more immune than another patient because they have more antibody. Secondly, titers represent an endpoint testing platform. That means you are not going to do this in private practice. This is a laboratory-based platform. The results are typically reported, if the antibody level is high, as positive. I have seen this on numerous laboratory-based reporting forms in which they will say parvovirus, quote, positive. It is absolutely essential that you understand what the laboratory means when they report a positive versus a negative test result. And what they are saying to you, the clinician, is that this sample has a significant amount of antibody in it. This is not a diagnostic interpretation. The diagnosis or the interpretation of the antibody test result, positive versus negative, is up to you. It is the clinician's decision as to how to apply that test result and interpret that test result in the individual patient. It requires days for a sample to be submitted, the testing to be conducted, and the reports returned to you. So it's not a quick process. On the other hand, the qualitative, or in the case of the VaccCheck test kit, semi-quantitative testing will provide you with a yes, I have antibody, no, I don't. Yes, I'm protected, no, I'm not. It is an in-clinic or so-called point-of-care test kit. Results are available. Usually you can perform this testing within 25 to 30 minutes. And this is I think, the significant advancement in this testing platform. But it is important to understand the difference between the two. One point that I must be very clear on: the laboratory reference standard of antibody titers have been correlated with the qualitative and the semi-quantitative test kits. There is, and this is important, there is excellent correlation between the laboratory titer test and the point of care test kits. Understand the technology. The point of care testing, the latest technology, as I mentioned at the beginning, is with the VaccCheck test kit. This is available today in many countries of the world. An individual dog can be tested for 3 different antigens and the antibody response to those. You're looking for canine distemper virus antibody, parvovirus antibody, and simultaneously adenovirus antibody. A separate test kit is available, at least in some countries, for feline panleukopenia. Notice that there is no test kit for herpes virus or calicivirus, the two primary causes of viral upper respiratory disease in cats. And there's a reason for this. The antibody response to calicivirus is predominantly local, IgA, mucosal immunity, whereas the immune response to herpes virus in cats is predominantly cell-mediated immunity. Circulating antibody is not a good correlation to protection for herpes virus and calicivirus, but it is an exceptional correlation with protection for canine distemper, parvovirus, adenovirus, and feline panleukopenia. The real opportunity that I see in the VaccCheck test kit compared to other test kits that we've evaluated is that you can do one patient or you can do multiple patients simultaneously. In this photograph, you can see that 3 dogs are being tested simultaneously. The technology is very straightforward in that the results card is dipped into various wells at timed intervals. The card actually becomes a permanent record of the patient's test results and can be added to the medical record. Results as early as 25 minutes. It takes me about 30, but about 25 minutes is the minimum time to complete the testing per patient. Now, I wanted to show you this slide. It's the slide that I've maintained for many years now and updated as new vaccines become available. Don't write this down. But I wanted to highlight the number of vaccines or the antigens used in vaccine development that are available to the veterinary profession throughout the world. Now, all of these vaccines are not available in all countries. But the point of this slide is to highlight the fact that there are many vaccines that we are using today. And I wanted to emphasize that you can purchase antibody test results for any of these. If we add the cat to that, there's about 30 antigens for the dog and somewhere around 115 to 120 vaccines, commercial proprietary products. And for the cat, there's almost 90 vaccines available. So the number of vaccines available to the profession is over 200. But for every antigen represented by the vaccines, you can test for antibody. Somebody can sell you an antibody test kit. The question is, how do I interpret the results? And I wanted to put special emphasis on this for you. This is an important point. Now, if you do submit samples of serum on an individual patient, or you elect to perform the antibody test within your practice using a test kit, and the results are reported as positive, it's very important to understand what a positive test result really means. And I would like you to think, I apologize, this is in English, pie, torta. But in the case of pie, I use this 3 letters to represent a simple way to remember the interpretation process for a positive antibody response. For example, a positive antibody test result could mean that the patient is protected. On the other hand, a positive antibody test result could mean that the patient is actually infected. It has a diagnostic role. And in other cases, other antigens, the antibody response indicates that the patient has only been exposed and is not infected and is not protected. So if you see where I'm going with this, it's very important for you to understand how to interpret a positive test result. Now, in the case of protected, I would like you to tell me which antigens, if the antibody test result is positive, indicates that the patient is truly protected. And for example, we can stipulate, and I've indicated this already, that the patient that has a positive antibody test for distemper, parvovirus, and this would include feline parvovirus and adenovirus, indicates that the patient is truly protected against exposure. Now, what about infected? When does an antibody test result actually mean that the patient is infected with the antigen, either a bacteria or a virus? I wish I were there with you and could hear your responses. But let me give you an example. Leptospirosis. Antibody testing to leptospirosis is not a test of protection. It is only used in clinical settings as a diagnostic tool and does not represent either exposure or protection. Important point to understand. There are many other important factors involved, excuse me, in leptospirosis. Another example would be canine Lyme disease. In the US, it's important to understand that we have allergies going on this time of year here, that Lyme disease can be used as a diagnostic tool if you are looking for antibody using a particular form of antibody, the C6 antibody, which is now being used in humans. And then feline immunodeficiency virus is also an antigen for which the antibody is actually indicative of true infection and does not correlate with either protection or exposure. Now, what about exposed? Some antigens for which a patient would have a positive antibody test only indicates the patient has been exposed to the antigen and is not either protected or infected. Ehrlichiosis is a very good example of that. Anaplasmosis is another good example. But there's one more very important example that I want everybody watching this webinar to understand, that a positive antibody test only means exposure, and that is rabies. In other words, a patient that has been vaccinated or exposed to the antigen would have a positive antibody test. An antibody test to rabies is not an indication of protection. In the international community, a rabies antibody titer that is positive in the individual patient only means the patient has been adequately vaccinated and does not correlate with protection. In some cases it will, but legally It is only an indication of adequate vaccination. In the context of the American Animal Hospital Association guidelines, the most recent version, we have added a section to that set of guidelines that specifically addresses antibody testing. And I wanted to provide all of you with a few indications. In other words, why would I test the individual patient? In the menu of options on the AHA vaccination guidelines, there is one section entitled Antibody Testing for Vaccine-Preventable Diseases. And I would encourage all of you to look at this section. This has been reviewed internationally, and we've been given very high marks for this section. In other words, this is a good study on why I would test an individual dog or cat for antibody. And I want to make one point very clear to you. Antibody testing is not simply a substitute for vaccination. I think a lot of veterinarians have the impression that antibody testing is designed to replace vaccination, and it isn't. I would much rather you look at the antibody testing platform as an opportunity to assess the response of the individual dog or cat to vaccination. Too much pollen. I wanted to briefly describe the initial vaccination series in the young dog or the young cat. All of you, I think, are familiar with the current recommendations that a young dog would get 3 doses of vaccine within the 10-week box between 6 and 16 weeks of age. Most commonly, 2 months of age, 3 months of age, and another dose at 4 months of age. The issue behind giving 3 doses of vaccine is based on the fact that we're trying to be present with 1 dose in the absence of maternal antibody. If you look at this purple curve, this represents maternal antibody. I think you all understand that if you vaccinate a young dog or a young cat in the presence of maternal antibody, that antibody will neutralize or inhibit the vaccine. So an important point is vaccination doesn't always result in immunization. This is very important to understand. Therefore, we give another dose at approximately 12 weeks of age when the maternal antibody level has fallen. And then we recommend a 3rd dose at 16 weeks of age when the antibody level should be very low, and then immunization will occur. And this is a characteristic pattern and a very common recommendation. When we speak in terms of antibody response to vaccine, it is critical to speak in terms of a threshold of antibody. There is a threshold above which the antibody level is protective. Below that level, the antibody concentration is not protective. If you read the graph correctly, what you will see is that very low levels of maternal antibody can still neutralize the vaccine, but the patient is not immunized. This leads to a window, a period of time during which this young dog is vulnerable. And that's why it is very important to avoid exposure for about 10 days after the last dose is given. But recent studies conducted at the University of Wisconsin have evaluated antibody responses to vaccine in large numbers of dogs. This is within the United States. And what we have learned, and this is new information, is that even vaccinating dogs at 16 weeks of age, there may be as many as 15% of your patients that are not immunized. This is due to extended interference from maternal antibody, leaving the question, did the patient actually become immunized or not? And for some clients, and I'm not saying this is true of every client, but there are clients who will want to travel with their dog. When the pandemic is over, the dog show circuit will begin again. People will be selling dogs internationally. And as a result of that, there will be clients who are curious to know whether or not that young dog has been immunized. The only way you can determine that is to test for antibody 2 to 4 weeks following the last dose in the initial series. If they are negative, that patient should receive another dose of vaccine immediately. So that, in my experience, has been perhaps the most common utilization of antibody testing in veterinary practice. But there's another one. We know today that globally, there are breeds of dogs and individual dogs that will not respond to vaccination. This is especially true with parvovirus vaccines. Not all dogs are immunologically capable of responding. This is not maternal antibody interference. This is a genetic factor in certain dogs, largely Rottweilers, but many other breeds are affected as well, in which they are considered to be a genetic non-responder. They have a very unique genetic flaw in their ability to recognize the parvovirus antigen. And as a result, some of these dogs will not ever respond to vaccine. And it is not possible to give them more vaccine and make them immune. The problem is these dogs will remain susceptible to parvovirus. At issue is the only way you can actually detect the genetic non-responder is to do antibody testing and determine that this dog has not developed antibody to parvovirus. Interestingly, we have recently recognized an increase in the number of pit bull terriers that are not responding to the parvovirus vaccine. And interestingly, it's not only the parvovirus vaccine. A smaller percentage of the global population of dogs will not respond to distemper virus vaccine. So this lends another opportunity, I think, in practice to provide objective information on whether or not this individual dog responded to the vaccine that you administered. This is new. Vaccine hesitancy in veterinary medicine. We have many websites available for your clients to look at today that address the harmful disease-causing vaccines that we give. Now, none of these websites are credible, but they do influence the owner. And we have recognized in many locations around the world, clients of veterinarians are expressing concern. You're over vaccinating my dog. Or this vaccine will cause injury. It will cause the disease you're trying to prevent. Or it's just completely unnecessary. Again, this is not for every client, but there are clients who will request antibody testing rather than routine vaccination. And the opportunity to do that is now available to you. So how do you interpret that? When you look at an antibody test result that's positive today, does that say it will be positive tomorrow? Well, in fact, in a way it does. And I think this is important immunologic point for everybody watching this today. Does a positive test result today give you information on what will happen tomorrow or next month or a year from now? And in many cases, it will. The reason is memory. Once a dog has made antibody, once you can document the presence of an antibody, protective levels of antibody, you are now able to say, even though we can't test for memory, you know that the dog that has made antibody has also developed memory. So in effect, that dog will be protected tomorrow and for really several months or years after that test. And how about this patient? I think all of us watching this webinar have encountered injury or an adverse event associated with vaccination. This is an acute reaction called angioedema. It occurs in a small percentage of dogs, but it is not predictable. The issue for the individual clinician is, although these patients do not die from angioedema, they do come back for another vaccine. The question is, what is their risk? If you feel there is concern or the client is concerned about giving another vaccine to this patient, the option is available to you to actually test that patient. If they are positive, you can avoid or delay vaccination. And this is what's being done in humans as children that have acute reactions such as angioedema. They know that children will become less reactive to the vaccine as they age. And this is probably true in veterinary medicine as well. But today that data is not available. On the other hand, if the patient is negative and it's a young patient, the concern you have is that that patient is susceptible. And it's going to be a clinician's decision whether or not to actually administer the vaccine to this particular patient. But at least it would give you objective information on their susceptibility. A question that I get so often in my presentations on vaccines is whether or not I need to continue vaccinating the elderly dog or cat. When do we stop administering vaccines? There is no data to provide information to the profession on that point, and therefore we don't publish recommendations. But in clinical practice, if you have an 8 or 9 or 10-year-old dog or cat that the client is concerned about giving unnecessary vaccines to, you can actually test that individual. If an 8-year-old dog has antibody to Parvo, distemper, and adenoviruses, they're immune for the rest of their life. Vaccination is not critical, and you could discontinue vaccinating them at that age. And then another indication in clinical practice is the management of the patient that has chronic illness. We're talking diabetes. We're talking, in this case, Cushing's disease. We're talking chronic kidney disease, cancer. All of these kinds of chronic illnesses that are systemic, that you and I deal with in practice, raise the issue over whether or not a vaccine is indicated. Rabies may not be an option. In many locations of the world, veterinarians are not legally allowed to exempt a rabies vaccine on the basis of medical issues. But for everything else, you do have that option. And in this case, you could actually test the individual patient. If a patient with Cushing's disease has a positive test result, then there really is no need to give the vaccine. And what I find interesting, and I think all of you know this, is that every vaccine manufacturer publishes in their data sheets the fact that vaccines are only indicated for administration to healthy animals. A dog with Cushing's disease cannot be considered healthy. So it really becomes a judgment call for you, but testing them and discovering that the dog would have a positive antibody test result for parvovirus, distemper virus, does indicate that the dog is protected and vaccination would not be necessary. If, on the other hand, the dog has a negative test result, this would only be interpreted as a dog that has lost the antibody response. An 8-year-old dog with chronic kidney disease probably is immune through memory, even though the antibody level has fallen to undetectable levels. The dog very likely is immune. If it made it until 8 years of age, it probably doesn't need to be vaccinated. But at that point, it would be your option to administer a vaccine or not if the test result was negative. This is an important one and somewhat controversial issue even today due to the lack of objective data. But if a patient that you're managing in your practice has a history of a documented immune-mediated disease, such as hemolytic anemia or immune-mediated thrombocytopenia, the risk of vaccination causing reactivation of that disease has been documented. It is not predictable. I cannot consistently tell you which patients should be vaccinated, which ones should not. But antibody testing gives you that option to actually evaluate objectively the antibody in that dog at that point of time. And if you tested this patient and it had a positive test result, then it would not be necessary to give a vaccine to that patient. I think one of my last recommendations here is probably one of the more important indications when dealing with clusters or a community of dogs. This applies to shelter medicine. Testing for antibody is a particularly valuable tool in the shelter setting to manage the risk of outbreaks. And knowledge of which patients are positive and which ones are negative gives the shelter personnel knowledge of which ones are protected and which ones are susceptible. And it's an important point. My experience suggests that there are two uses of antibody testing in animal shelters. One is to acquire knowledge of the antibody status at the time that dog or cat is presented to the shelter. Knowledge of that gives you great insight on the susceptibility or the vulnerability of the individual population. More and more shelter personnel are using antibody testing when the outbreak occurs. If there is an outbreak of parvovirus within a shelter, testing would be conducted. Those animals that are protected with a positive test result are allowed to remain in the facility. Those animals that are not or have a negative test result would be placed in foster care and removed from the facility. The concern is that so many shelters have elected to euthanize all of the dogs within the facility when 2 or 3 dogs develop parvovirus or distemper. This is an important option in community health, if you will, in managing the risk of an outbreak within a shelter and saving lives. There's another indication that you may have encountered. Many breeders will require or request antibody testing prior to breeding. Their goal is to determine the antibody level in the bitch prior to breeding in order to assure that this female will convey colostrum or maternal antibody to the puppies. Many clients that we've interacted with have the assumption that the higher the antibody level in the female, the more protection will be conveyed to the puppies. And that is not true. But antibody testing does provide the option of knowledge that, yes, this female does have antibody, and that antibody will be conveyed to the puppies during nursing within the first 3 days of life. And there are other indications. There are probably more indications than we even have identified, such as some people drive a car that is smaller than the dog that they own. And as a result of this, they are not compliant with your booster recommendations. Today, we are recognizing so many practices that are dealing with clients that are overdue with their dog or their cat for booster shots or revaccination. Some of these clients have expressed a concern about giving a booster dose of vaccine and would prefer to just simply test for antibody. So here is yet another option. I'm sure you could probably come up with more in your experience. But I wanted to emphasize the fact that as we conclude our discussion on antibody testing, that there are many options and indications for utilizing antibody testing in private practice. I've tried and hope to communicate with all of you on a few of those indications, what they mean, and what is actionable. What does that antibody test result do for patient management? Well, I hope you found this helpful. I wanted to thank, again, all of you for attending this webinar. I apologize for the pollen and the voice issues, but we'll get through that. I want to also thank Biogal for their willingness to sponsor this presentation, and a special thanks to the translators who have worked so hard to communicate this information to a global audience. Thank you very much.
Thank you, Dr. Ford. That presentation was really great. I definitely learned a lot. We did have about 40 questions submitted to the Q&A. So we will try to get through some of the more common questions here on the webinar, and then we will look forward to some written answers for the rest of them. So one pretty common question that was asked is, oh, let's find a good one here. So we had someone that asked, this is Christian Dunavichier, and it says, this applies pretty well for parvo virus, distemper, and adenovirus, but what about the other illnesses protected through a multivariant vaccine? What about hepatitis? Is there still a need for vaccination in dogs with positive antibodies for distemper, which was also vaccinated for that multivariant vaccine?
Megan, if I understand the question correctly, there is a concern that adenovirus occurrence might be so low in the world today that there's no need to vaccinate and no need to test. But I think all of the experts agree that canine adenovirus, or the hepatitis virus, still exists. And if we did stop vaccinating, then we would see a recurrence of this virus. So it is important, I think, in the context of combined vaccination, the distemper, parvovirus, and adenovirus, and the opportunity to test for all three of those for antibody remains an important factor today.
Thank you for that answer. We did have Cindy Wasserman ask, she states, I thought that vaccine titers could be falsely low if they haven't recently been exposed to the antigen.
Well, Cindy's question is quite appropriate. And I think that we know today, with several studies having confirmed this, that the antibody levels actually for distemper, for parvovirus, and for adenovirus remain at elevated levels much longer than we realized. But the important point to this question is that if you have ever documented a positive antibody test for distemper or parvovirus or antibody or adenovirus, if they have antibody to those, they have developed memory. And that memory, at least for parvovirus, is now recognized to last for the lifetime of the patient, even though the antibody levels may fall without stimulus or booster vaccination. The patient would still very likely be protected. In the face of a negative test, it is always appropriate to administer a booster and actually raise the antibody level to assure protection.
Thank you for that answer. We do have a few questions around vaccine non-responders, and probably the most common question was, at what point should we say that this dog is a non-responder? So maybe you could give some more signs of non-responders.
Well, this is actually a very good question, Megan. The non-responder in veterinary medicine, mostly dogs, some cats apparently, is a global phenomenon. They occur throughout the world as we speak. Parvovirus non-responders, clearly the most important ones. It happens the most often. The diagnosis, the determination that a dog is a non-responder can only really be determined by actually doing an antibody test. The first one I would recommend as early as 2 weeks after administering the last dose in the initial series. For example, the dog would be about 18 weeks to 20 weeks of age when that last dose is given, and then another testing would be done 2 weeks or so afterwards. If that test is negative, the dog should be revaccinated and retested. If on retesting, the dog is still negative, 2 consecutive negative tests with 1 vaccination in the middle is a diagnosis that the dog is a non-responder. And it's important to understand that the dog is susceptible if exposed. Well, that's really the only way, short of challenging the dog with the virus, of knowing they're a non-responder.
Excellent. So I think we are going to respond to the rest of the questions in written format. Dr. Ford, we really appreciate your time and all of the information that you shared. This is the conclusion of the webinar. Thank you everyone for attending, and the recording session will now stop.